pediatrics will be, what do you do first kind of questions. And this will kind of help you to prioritize what you should take care of first. Okay. Let's see. So what is bronchiolitis? It's a common cause of respiratory distress in children under age 2. It is an acute disease that causes inflammation in lower airways of children. The inflammation causes the bronchioles to swell, which affects the expiratory airflow. So bronchiolitis, it's going to be the most common cause of respiratory distress in children. It's very, very common. And basically, it's just inflammation of the airways. When they're inflamed, they cannot function properly. And so then you get signs of respiratory distress. Okay. Just a little A&P refresher. These are the lungs. The bronchioles are right here, these little stems, and it's the alveoli. So you can kind of see, how they affect the breathing when they're swollen. It's just basically these little tubes here at the bottom that transport air throughout the lungs. Okay. So why is this important? I know in adult nursing, they have other causes of cardiac arrest. But for kids, the most common cause of colds is respiratory distress that progresses, it's not treated properly. So it's very important for registered nurses to be able to recognize the signs of respiratory distress, and be able to identify them before the kids get to the point where they're cold. And, just like I was saying before, this is one of the most common things that you will see as an RN, and we all know that the RN is frequently the person that is with the patient the most often, the longest amount of time, and they'll have to identify the changes in condition. You'll be the first one to see that the child is having trouble breathing. Like on the floor, I can remember when I was working, you're going in there at least every 4 hours at the bare minimum. You're going to be the one to identify that there's a problem and have to call the physician on call and let them know what's going on. Let's see here. Yeah, I already repeated that part. Okay. So what causes bronchiolitis? It's caused by multiple viruses, different viruses. It's a viral infection. So in the United States, RSV is responsible for the majority of the cases of bronchiolitis. Other causes include influenza and adenovirus. I've even seen patients with COVID have bronchiolitis. So that's not in there, and it's just sharing for what I've seen working through the pandemic. We've seen kids with babies that have COVID, they'll have signs of bronchiolitis. So apparently that one, that virus will cause bronchiolitis as well. Okay. So the most common cause of, did I miss a slide here? Let me see. No? Okay. So this is just a little bit about RSV. So RSV, like I was saying, is the most common virus that causes bronchiolitis in kids and babies under 2 or children under 2. The incubation period is usually around 4 to 5 days. It's most common in fall and winter. So I can remember when I was working as an RN, every October through March or so, we would have the floor be full with bronchiolitis patients. So you would see it all the time, every year around that time. Pediatrics is one of those specialties that is dependent on the time of year. We get busy during the fall and winter months. The summer is not as busy. So that's one of the things to kind of know if you work in that area. It's caused, by respiratory secretions, kids sneezing on each other, coughing, not washing their hands, those kind of things, which, kids under 2, they don't really wash their hands too much. They don't really know about not sharing things. So that's where they kind of get it from. Symptoms. So sometimes initially the baby just may be fussy. I've seen it sometimes where parents just come in, oh, my baby's real fussy and they're not feeding well. And then, you listen to their lungs, they may be wheezing. So sometimes it's not like an obvious thing like it is with adults. An adult can say, I don't feel well, I can't breathe. Babies are a little bit different. So it's just important to look for signs that the child may be ill. So normally for pediatric patients, especially the ones under 2, a lot of times it just starts off with fussiness, poor feeding, sometimes fever. You know, the respiratory distress, the nasal flaring and retractions, we'll talk about that. That's usually something you see later on, and that's when they start to get in trouble when you see that. Let's see. So this is just a little picture I found online to kind of explain signs of respiratory distress in pediatric patients. Mainly, you'll see nasal flaring. You see how the nostrils are kind of flared out. This is supposed to be cyanosis, I think, but that's kind of a late finding. Hopefully, we don't see that too often. We want the goal is to intervene before you see that. But then the retractions, you see how it's kind of indented here, and the intercostal retractions here. Okay, these are like the signs normally, like when when you're in a hospital, these would be the signs that you would see, and you want to start either calling a physician or start the treatment plan. And we'll get to like the treatment for, like, if you have orders to give breathing treatments, you want to go ahead and start that if you see the baby like that. So hopefully no cyanosis. That would be late, and we don't want it to get that bad. Okay. Just some risk factors for severe RSV: being premature, heart or lung disease. So all those tetralogy of Fallot, heart murmurs. Those are that's one of the bigger heart defects. But a lot of kids with like heart murmurs, you'll see a lot of that. VSDs, ASDs, those kind of kids, they're like more risk for having a severe RSV. And of course, less than 6 months of age. So the babies, the small babies that are born and they're, less than 6 months during the winter months, they're at risk for getting pretty bad RSV. Okay, so what are we going to do about it? What can the nurse do? Okay, mostly it's supportive care because it's a virus. Antibiotics will not help. Suction. This is like the most important thing with RSV. They would admit patients to the floor, and we would just have orders to do nasal suctioning on a certain schedule. And it may sound like it doesn't help, but I've seen times when the suction in the hospital is pretty good, because it's like the suction canister, and they used to have these little wands that you attach and you suck out the baby's nose. I've seen that make a world of difference. You can just suction the baby real well, and you will see a great improvement in the breathing. So it really does work. That's the thing you want to try first when you're dealing with a kid with bronchiolitis. Normally, they recommend at least before meals and before the baby goes to sleep. Now, the albuterol. We used to give albuterol all the time for bronchiolitis. Now, I still see it a lot, but it's kind of, some studies show that it helps and sometimes it doesn't. So what I've seen more recently is them kind of doing like a trial of albuterol, but of course the physician will order that. But just so you know, FYI, sometimes you will see albuterol to help if the child is wheezing. When the airways become inflamed, sometimes you will hear the wheezing. And then if the wheezing occurs, a lot of times they'll do the albuterol. Sometimes they won't. They'll just have you suction and monitor the child and just suction really well. Another thing you'll see in the inpatient is MPO. So a lot of times if the baby is tachypnic, usually I'm going with like an infant, because those are the ones that normally are in the hospital like 6 months or less. Normally that would be like over greater than 60 is tachypnea for a baby that age. Sometimes they'll have a higher rate before they stop feeding the baby and do IV fluids, but sometimes they'll just say greater than 60 MPO. And the reason why I just want to say this as well, the reason why I'm kind of going from an inpatient point of view is because most of the RN jobs for pediatrics are inpatient, ER, children's hospital, sometimes in a regular hospital on a children's ward. That's why I'm kind of going from the inpatient. That'll be more what you'll see as an RN, okay? All right. Sometimes they need oxygen, ventilation. This is kind of when they're getting really bad. Sometimes they end up in PICU. IV fluids, pulse ox monitoring. The IV fluids is pretty standard. Pulse ox is pretty standard. Hopefully, we keep them from getting to the mechanical ventilation and the oxygen, but sometimes it happens. But hopefully, they don't get that bad. Okay, so depending on where you work, they may have rapid response. I know some hospitals, we used to have that. So, like, if we saw the child was not getting better, you could call rapid response, and they would kind of help you out, or you would call the MD and let them know. Okay. Retractions, nasal flaring, increased respiratory rates. Sometimes you can hear audible wheezing. That would be another thing. I didn't put it on here, but that would be another time to call someone to help. If you see those, you should notify the physician of worsening condition or call a rapid response. Now, I will add, sometimes when you work on the floor, that they'll have albuterol PRN. Like if you have something like that, you probably want to try the albuterol, but still, I would still let them know what's going on. Like, hey, I'm going to go ahead and get them albuterol. That way, if the child is worsening, just so the physician or MP or PA or whoever's on call that day will know what's going on. Okay. So I've been a nurse, like I said, for 18 years. When I first started working in pediatrics, again, we would have, the floor would be filled with bronchiolitis, RSV babies from maybe October to March. Now, it's gotten a lot better because they have vaccines to help. We don't have necessarily a treatment for RSV, but the vaccines help prevent severe RSV, so that's a good thing. They used to just be Synagis, but now they have these actual vaccines, okay? So the mom could get one during pregnancy. If the mom does not get a vaccine, the babies can get they can get the antibodies, okay? So this is more antibodies than the vaccine. The mom is an actual vaccine, so I guess I should have worded this a little better, but yeah, there is a difference. They get the antibodies, the Beyfortus, but these help. So now, a lot of times, the babies do not get as sick, so that's a good thing because it used to be really bad. And then I just have some references here. I don't know if anybody has any questions, but what I do want you to take from the presentation is that pediatric patients are not little adults. The things that you learn in adult health, they're a lot different in pediatrics. You're going to see a lot of respiratory distress, but I want you to treat that very important. Like that's very important for pediatric patients because that's what leads to the cardiac arrest. Not like the adults that have heart attacks and all these other things. You won't really see that too much. So if you take anything from the conversation, just take when you're dealing with pediatrics, the respiratory is very important. Making sure that they can breathe effectively, and just monitoring them. Just the biggest thing I know pediatrics' specialty is just recognizing that it's different from adults. Okay. Does anybody have any questions for me or?
I have a quick question. Mm-hmm. So if we are on the treatment plan, do we give steroids for these patients? There's patients
they don't
that
usually
do they
give
usually
steroids.
get one?
Some of the research is controversial. I know some physicians will give steroids, but the most current care normally you don't give steroids. Normally it's just like albuterol and kind of monitoring the oxygenation. I guess if the child was they may give steroids if the child is very, very ill in ICU, but normally they don't give steroids unless I think I have seen it before, like when a child is severely ill, but for most RSV, there's just albuterol, the suction, the oxygen. Now for croup, we give steroids normally, but normally they don't give steroids anymore.
Okay. Any positioning that will be better for the kiddos to increase respiratory efficiency that we can recommend to the parents? Or anything like that.
So what I would say for them to sit the baby up when they're feeding, because I've seen some parents, I don't know why, but they'll have the baby laying down when they're feeding them. So when they're congested, I would say to sit them up when they're feeding, and then just suction them really well before you lie them down. That helps with the secretions.
Yeah, absolutely. Okay. I think that's pretty much it. You did excellent, for real. Seriously, I enjoyed the way you tackled it, and also the The PowerPoint very clear and straight to the point, not clouded and everything. I don't think we have any further questions for you at this point. We will be contacting you for sure in the next 24 hours. And last question for you
Okay.
will be, if, say, we give you this position, know that this is not available right now because the students are still in school. They're starting exams. The NCLEX is after this term, 3 months time or so, by May when they graduate.